A very good day, my dear students. I hope that by this time we would have appreciated the importance of autopsy from our examination point of view. I take you to Autopsy of the Brain, Part 2. I hope you identify the structure on the screen, the Grant Medical College and its associated JJ Hospital, where I was posted as a postgraduate student. And my thanks are due to Professor Langever, who was elaborate and simple in his descriptions. I would like you to kindly follow this quote also. In the earlier class, we had seen the structure of the brain. Pathological anatomy is not as complicated as pure anatomy. We will have to remember and follow. Precision is not the matter. So these are the structures that we will have to remember, and these are the lobes, and there is a neocortex and an allocortex. There are different methods of cutting the brain. One can be a coronal section, another can be a sagittal section. In this case, it is a horizontal section, wherein there is a display of the gray matter and the white matter, and the various folds of sulci and gyri could be made out from this. As I mentioned in the earlier class also, you find that there is enough amount of space for us to maneuver between the skull and the brain. This is a beautiful structured diagram from this particular source, wherein they have marked, or rather demarcated, the frontal, parietal and occipital lobes from each other. And also there is a display of the cerebellum, the brainstem and the pituitary. The temporal lobe stands somewhat lateral and behind. In this picture, which we had seen earlier also, you find that one hemisphere has got the meninges intact, whereas in the other they have been removed. And what we should appreciate will be these points, whether they are symmetrical, the size, whether it is shrunken or edematous. Meninges, are they transparent or translucent? Is there any widening of the sulci? Areas of hemorrhage, consistency as you feel, and the central sulcus, is there any widening? There are three regions, obviously, the frontal, the parietal and the occipital. If you remember these three, there are many subdivisions which you people can go through. The rest are free. My dear students, this is the vertebral column and the spinal cord within it. And I am finding the branches of the spinal nerves. What is important is the vertebral column and the spinal cord do form an important part of the examination of the central nervous system. For this, I would like you people to kindly appreciate the lateral view of the vertebral bone. And this is the intervertebral disc. This is the body of the vertebrae, and you find that there are the various processes. There will be a lateral process, and then there will be a posterior process. And therefore, there will be the os for the outcoming of the nerves. The same thing, if it is seen from superior, you find that there will be the process as such, and then this is the spinal cord from which the spinal nerves emerge. Now, what is important is there are two methods of approaching the spinal cord. One school of thought is you make the patient lie down in the, or rather the corpse in the prone position, and then it is severed here. The second one is the body is in the supine position, and then it is cut across the lamina over here. The second approach, that is the posterior approach is recommended because there can be less damage to the spinal cord or the nerves. This we all know. It is a little complicated, but I would like you people to kindly remember only three things. One is the vertebral artery, two, the basilar artery, and three, the circle of Willis. After this, you people can look for whatever pathology you like. It can be an aneurysm, it can be a hematoma, it can be a hemorrhage from within, etc. Also, you can see the blood vessel traversing the vertebrae and reaching this particular place. These are beautiful diagrams which you people can bear in mind. The spinal cord, it is usually a neglected area because autopsy is not completely done in this. Exposure is a little tedious. The patient, as I told you, or rather the body, is kept in a prone position, the shoulders are supported, the head turned to one side, and again supported with a towel. Otherwise, it will be hanging. And it has to be open along the midline. Then sometimes there can be certain abnormalities which can be looked for. In this case, I find that there is a gap, and sometimes there can be a meningocele or a meningomyelocele from that, which we shall be remembering. Please have these pathologies in mind: a spina bifida, a meningocele, a meningomyelocele, or rare pediatric tumor. Sometimes an astroblastoma can emerge from within a spinal cord. Also, there can be metastatic tumor deposits, including leukemic deposits in the spinal cord, which should be looked for. Regarding the dissection of the spinal cord, there are two approaches. Most commonly followed is the posterior approach. These pictures have been retrieved from Ludwig. There is a central incision. The skin and the fascia are reflected. Look at the reflections being done over here so that the cord is exposed. The vertebral arches are removed and the dura reflected. The advantage in this case is it is easier. The cervicospinal region of the cord can be visualized. Also, if the patient has had any amount of contusion or fracture, it could have been visualized. Secondly, there will be minimal damage to the spinal cord as such by this posterior approach. Sometimes, if you are lucky enough, you can remove the brain along with a good part of the spinal cord itself. And this is the anterior approach, which I had mentioned earlier. In this one, there can be damage to the spinal cord or the nerves. Forget the text over here. It is only for reference. But this picture was so very beautiful that I could not avoid it. This is a model of the ventricular cerebrospinal fluid circulation. You are finding the various ventricles, the third ventricle, and from there, you find there is a fourth ventricle. You find that there is a circulation of the cerebrospinal fluid. So this has been modeled so very beautifully, and the credit goes to the reference adjoining. In the external surface, usually, as I told you, you people will have to look for the various narrowing or the edema, etc. Sometimes we can look for the vasculature also and the adjoining pathology, any malformations of the blood vessels. And this is the base of the normal brain. What you people are seeing on the screen are contributions, or rather creations by Vesalius. At the base of the brain, one will have to look for the nerve tracts, corpus callosum when it is cut sagittally. And underneath the cerebrum, we'll have to look for the thalamus, the hypothalamus, pituitary, etc. These are drawings by Andreas Vesalius. And the Science Photo Library has given me a beautiful picture of this, which is worth projecting. There are different methods of dissecting the brain. One is supposed to be a fresh dissection. And this is the comment of Ludwig regarding a fresh dissection. It is not of much use. It is like a book immersed in water. So not of much use. Obviously, it will be collapsing. It will not be very consistent. But of course, we can look for arteries for thrombosis or embolism. This again is something that we will have to retrieve from a fresh, unfixed brain. All these matter for the case of research, molecular pathology, or diagnosis. For example, the cerebrospinal fluid and any of the elements that you people require can be retrieved from a fresh, unfixed brain. But most of the study will have to be done only in a fixed brain. And in a case of autopsy of the brain, what all should you look for? One is any large lesion, ventricular asymmetry. The asymmetry alone can be clue to an underlying pathology. Small lesions can sometimes be missed, and early infarcts can also be missed. These should be borne in mind. The fresh specimen should be supported by refrigeration for a period of about 30 minutes before you cut. There are a number of diseases which can be diagnosed from these, such as the degenerative diseases, infections, metabolic diseases, microbiological and biochemical diseases. For all the others, a fixed brain is needed. So this is the sagittal section. As I told you people, sometimes it will be difficult for us to imagine or even localize. In such a case, it can be superimposed onto an MRI picture wherein you will be able to get a clear idea of about what you are grossing at. And in this, I am able to see a display of the vessels, the corpus callosum, etc., which are labeled over here. I would like you people to kindly go through the names, because if an examiner wants to teach you, he can ask you, but it is highly unlikely. As I told you, the dissection of the brain and the spinal cord is based on the symptoms with which the patient is presenting, the CT scan or the MRI, the other biochemical findings. Whatever be it, you find 3 coronal cuts are given, not much, so that you have an idea about what is happening. Some authors suggest that one half of the brain be cut coronally and the other half preserved as it is for further examination. The brain stem is avoided during the dissection. There is another concept that we people should be at least aware of, which is called as brain banking. Just like blood banking, etc., you find that there is a brain banking. This is a normal brain and this is an Alzheimer's brain that is being preserved. And see what all can be diagnosed or what all can be stored as such. These all have been clinically diagnosed and it can be a wonderful source for research. Sometimes we all want a healthy brain, and this is an instance of a wealthy brain, the richest person in the world. And this again, a continuation of the brain banking. This is a particular source from which I have retrieved the specimen. It has been well fixed, probably by means of perfusion, and it is stored. You find that there are numbers that are being given and a wonderful storage interior being maintained. And sometimes you find that almost the entire section, or at least half of it, has been mounted on a wax block. And this credit goes to the particular author over here. Homewood photograph is the source of my picture. And from all of this, you can do a histological study, immunohistochemical study, molecular study, or even biochemical study. What do you see in the brain? Earlier, I have told you only about the method of opening, what all do you examine. You should always look for lesions. And when I say lesion, Sometimes you can see the lesion. Many a time you can feel the lesion because it is going to merge imperceptibly with the surrounding parenchyma. You can compare with the surrounding areas, correlate the right with the left, and sometimes it is a post-biopsy wisdom. This is a case of a basal meningitis with opacity of the meninges. And also, the circle of Willis is notorious for a hemorrhagic infarct, in which you will have to look for any of the atheromatous plaques as such. Yellowish in color, distended, there has been a stasis. Or sometimes you find that there is a hemorrhage and also the surrounding tissue. I do not know whether it is normal or abnormal. It can be going in for an infarct, a hemorrhagic infarct. I am showing you the various lesions. 1 is a meningitis, 2 is an atheromatous plaque, 3 is a hemorrhagic infarct. Identify the structures over here. For this, I would like you to kindly compare it with the sagittal picture that is given over here and the lesion, the hippocampus and the corpus callosum. Slicing the brain. This is of importance from our topic point of view. This is a machine in which you find that the brain has been kept or rather fixed, and you have got another cover which will be able to maintain the plane of cut. After which you find that the brain is cut in whatever direction you people want. Usually you get an anterior to posterior section. You will have to cut the lesion along with the surrounding normal brain. Suspected lesion along with the location, according to the location as such. Based on the clinical history, MRI, CT, etc. Sometimes an angiogram can guide us to the lesion. A contrast X-ray can also help us. I'll be showing one of the pictures over here. This is another area that has to be cut. This is the cerebellum and the brainstem. This is separate from the cerebrum as such. You find that the thumb is supporting it and the index finger is inserted into the plane of cleavage between the cerebellum and the cerebrum, after which you will be able to dissect it. See, there is a sampling that is being done by another hand. And this is what I have been telling you people. An angiogram sometimes can be mandatory for us to identify a lesion. I don't think you'll be able to enter a brain and identify a berry aneurysm. For all these, an angiogram can be mandatory. This we have already seen. From where will you give the bits? For that, again, we should have a picture of the normal brain or an MRI of that particular patient. So when you cut it into planes, you will be able to locate areas which are different from the others from which sampling can be done. It can be done from the gray matter, the white matter, or both. And as I told you earlier, you can see the lesion, you can feel the lesion, you can compare it with the MRI, or sometimes it can correlate with the clinical history. Tumors as such. Tumors, sometimes you are lucky, but we do not know the extent of the tumor. This is the case of a glioblastoma. It is rather kind of diffuse. Usually it is said that a tumor doesn't cross the midline. In this case, it crosses or rather pushes, and then I'm able to find a lesion over here. This also, it is well circumscribed. The advantage of a brain tumor is, even when it is benign or sometimes in early malignancy, when it grows, it causes a tremendous amount of pressure so that the patient will not be able to withstand it. He is rushed to the hospital and an earlier diagnosis done, unlike other tumors which would have already gone in for grade 4. So this is a tumor with areas of necrosis. As I told you people earlier, you will be able to diagnose or locate a tumor according to the region. The ependymoma and the choroid plexus papilloma are all lesions which project into the ventricular cavity. Look at this particular picture, well circumscribed by the cerebellum. I find a tumor with not much of necrosis or hemorrhage. And this again has got a little bit of hemorrhage, both of which are ependymomata. This we had seen earlier also. You find that the brain parenchyma is unaffected, but the tumor is clearly arising from the meninges. So, what are all the lesions that we had seen so far? We had seen the meningitis, we had seen the areas of hemorrhages, vascular abnormalities, or areas of infarction, and then the tumor. Tumors can also be arising from the brainstem. So here there is a lot of necrosis, brain tumors or brainstem tumors in a young child. Think of a medulloblastoma. A schwannoma, more or less a linear tumor, and it is well circumscribed, arising from the eighth nerve. It appears pseudocapsulated. Sometimes there can be a dumbbell-like constriction. Glistening, white, classical picture of a schwannoma. Yet another lesion that can be seen in the brain can be an abscess. So, meningitis is one of the septicemic lesions. Another one can be a brain abscess. Brain abscess, it is a classical example of a liquefactive necrosis. And unlike the other tissues, there is very little fibrosis. This again is a blessing in disguise or the best of the worst, because there is no surrounding fibrosis which pulls the parenchyma. I find a well circumscribed lesion, that is a brain abscess. Sometimes there can be multiple petechial areas of hemorrhage which can be indicative of emboli or thromboemboli. One of the lesions, we have already seen specimens of this Alzheimer's, and in this I find that there is a widening of the ventricles, of course, asymmetrically, and then there is an atrophy of the parenchyma, a lot of space in between, which is classical of Alzheimer's. Also, diffuse plaques could be seen throughout the parenchyma. There are other features. Kindly go back and read. This is an essay question by itself. We are nearing the end of the class. So a picture like this, what all should you people be remembering? As I told you, you find that there is a vertebral artery, basilar artery, and then the circle of Willis. What are the modes of fixation? What are the lesions I can find in the base of the brain? Is it transparent or is it translucent? Am I able to figure a hemorrhage or a tumor? Such things. And ultimately, I should realize that this strong basilar artery is used for fixation of the brain. Watershed area is another one. It is an area in between the regions of supply of two blood vessels, so that it appears in between vasculature, goes in for infarct. The references are these: Ludwig Moseley, Autopsy by Sir Langever, and Otto Sapphire. I would like you people to kindly go to the references and listen to the classes over and over again, because the pictures have been taken with a lot of difficulty. The quote of the day: fill your brain with giant dreams so that it has no space for petty pursuit. A superb one. I think it is very much mandatory for people who complain. Thank you.